हाय फ्रेंड्स, आई एम डॉक्टर आशुतोष गुप्ता और आज बात कर लेते हैं सिस्टिक हाइग्रोमा के बारे में, राइट। तो सिस्टिक हाइग्रोमा इज ए रेडियोलॉजिकल डायग्नोसिस, पहला। दूसरा, व्हेनेवर वी आइडेंटिफाई दैट द एंटी न्यूक्लियर ट्रांसल्यूसेंसी इज ग्रेटर देन 99 centile for the CRL, and we do have the subcutaneous fluid edema all throughout the body, two non-consecutive areas having the fluid, and the dorsal edema, meaning thereby that the edema is there, swelling is there onto the dorsum of the feet as well as of the wrist. So these are the pathognomic findings for the cystic hygroma. Cystic hygroma is radiological diagnosis है, and we believe that most likely it is um, a Turner phenotype, right, and a lymphatic abnormality which is there in the fetus. So the risk of recurrence is negligible, right. So we hardly do investigate the cystic hygroma further up, right. But this is a very interesting case in which we investigated the baby further up in a cystic hygroma. वो मैं दिखा देता हूँ. So this is the fetus that we are examining at 12 weeks and 2 days. Okay, so this is the nuchal translucency, which is definitely classifying it to be cystic hygroma. चेस्ट को देखिए तो बैरल शेप चेस्ट या बैरल, राइट. तो ये जो चेस्ट है, ये चेस्ट में ही परेशानी है. सो इट इज अ बैरल शेप्ड चेस्ट, राइट. थोरेसिक हाइपोप्लेजिया, right, which is under evaluation. So we are doing the baby with TVS, and this is the cystic hygroma that we are seeing. So ये cystic hygroma तो है ही है, and which is under evaluation. Now we are identifying is this कि ये thoracic hypoplasia है, right. So thoracic hypoplasia is this that probably we could be the first finding for a cystic hygroma. Okay, so thoracic hypoplasia is under evaluation at the moment, right. And now we are just trying to look around the plausible reasons. So this is the humerus, arm bone hai, which looks good for a 12 weeks and 2 days, right. Okay, but eventually the all the limbs, they have to be measured so as to identify whether we are dealing with a micromelia or not. So this is the humerus, so we have measured it out and it looks good to us. And then we have moved on to, so this is the club foot, and then the tibia, which looked to be short to us. So first impression was this that, and then the second feet, which is also a club foot, right. So bilateral club foot, and the this is the femur, this is the thigh bone, and which looks good. तो ये ठीक दिखाई देती है, but we definitely we are dealing with the club foot which is bilateral. Okay, and then we're trying to look around for the ossifications, and so this is club foot, right. and and then we are going further up so as to identify, so there is no polydactyly, right, कोई extra digit नहीं है. And then we are seeing the skull, तो इसमें कोई ossification की defect नहीं है, so that is ruling out osteogenesis imperfecta. This is the fluid which is there all throughout the body, so this is going lower down, and so cystic hygroma की diagnosis तो confirmed है. And so we are just trying to look around, so polydactyly, so which is not there, and then we're trying to look around for the ossification of the whole spine. We don't have any defect with the ossifications. The thigh bone looks good to us, so meaning thereby that the major, so this is the club foot, and this is the club foot, and then we are seeing the thigh bone. The ossification looks good to us. This is the thigh bone, right. And then the head also, the ossification of the head looks good. So we are dealing with cystic hygroma and pulmonary hypoplasia at the moment. Cystic hygroma can have a lot of different genetic etiologies, and at the moment, the major ultrasound finding is a pulmonary hypoplasia. So we are just trying to look around for the differentials for the pulmonary hypoplasia, and so we don't have any polydactyly. So that goes more in favor of an short trip polydactyly syndromes, and the ossification of the skull, as well as we don't have any fractures in the ribs, so that goes against an osteogenesis imperfecta type 2 and type 3. The limb bones, major limb bones, meaning thereby that the humerus and femur, they were normal for the gestational age of 12 weeks and 2 days, so that practically ruled out thanatophoric dysplasia. And but what the major finding we identified was a short band tibia with a bilateral club foot, right. And so meaning thereby that from a normal cystic hygroma, and we identified it to be a Turner's and all those stuff. So now we are and dealing up with cystic hygroma, with pulmonary hypoplasia, with bilateral club foots, and short band TBS. So this could be some sort of an skeletal dysplasia, camptomilic or campomilic dysplasia to be precise. So in usual circumstances, what happens is this, that I have told you earlier also, that cystic hygroma is a radiological diagnosis and we hardly do get them investigated. And if need be, we might get an sort of an POC karyotype so as to identify the Turner or Turner phenotype. Noonans can also happen in 5% of the cases, but in this case, we wanted a complete genetic evaluation in greater depth so as to identify what exactly that we are dealing up with. So there could be some thanatophoric dysplasia to oxygen imperfecta to campomilic dysplasia to short reproductively. It is not that short reproductively they don't have sort of an or they do have polydactyly in all the cases. Yeah, so meaning thereby that we would need to get this fetus investigated in thorough or deeply so as to identify what is the genetic root, and depending upon the clinical situation or the genetic mutations being identified, the risk of recurrence in subsequent pregnancy could vary from 25% if it is a SRP or short reproductive syndromes to 1 to 6% if we identify it to be an homozygous achondroplasia or thanatophoric dysplasia. So what I want to tell you is this, that even though radiologically it looked like cystic hygroma, but in a greater depth we identified that it is something else and it is presenting a cystic hygroma, and therefore greater depth genetic mutations or analysis of the baby is warranted so as to identify what exactly that we are dealing up with, and what would be the risk of recurrence in subsequent pregnancy, right? So the counseling would change similarly whatever the mutation that we identify. Okay, thank you very much for your patience.